Good afternoon, everyone. Welcome to this week's HPL seminar. Today our speaker is Thomas Bugowski. Thomas is currently a MSc student in Dr. Janet Wronski's lab. He's very close to finishing his degree, hopes to defend in May or June. Prior to beginning his master's degree, he completed his BSc here in kinesiology at the University of Calgary with a specialization in biomechanics. After graduating with his bachelor's, he worked for 18 months at Braceworks. This is a company that specializes in custom orthotics and braces. His work with the patients largely inspired his interest in doing research into bracing and orthotics, and as well as how braces might influence gait parameters. Now, Thomas hopes to continue this line of work and really make an impact when he begins his PhD with Dr. Janet Wronski's lab in the near future. Now, in his free time, what Thomas does is largely determined by the size of his wallet. When he's flush with cash, he likes to go snowboarding. If he's broke, you're very likely to find him wasting his time on his computer. So today, Thomas is going to be presenting his master's work, examining dynamic bracing of Pectus carinatum, a quantitative analysis. Whenever you're ready.
All right, thank you. All right, so with just a quick show of hands, I'm just curious, who has actually even heard of Pectus carinatum? Just in this room. You don't count, Ricky, because I've probably talked about my research with you. Or no. All right, okay, so good. So this will hopefully be an educational experience for all of you. So let's just start off with what is actually Pectus carinatum. So you can see on the picture to the right here, it's nothing very complicated. It's simply just a protrusion found in the sternal area of the chest. Now again, not a lot of people know about this deformity, so a lot of people actually think it's rare, but it's more common than you think. It occurs in about 1 in 500 to 1,500 adolescents. And there's really no major concerns with this deformity. Very rarely will we see anyone with, cardio or pulmonary issues. It's more so psychological. So everyone with this deformity, they might avoid any activities where they might need to expose this protrusion. So swimming would be an example of that. Now, how does someone actually get this deformity? Nobody knows. However, in the literature, we do see anatomical differences between someone who's normal and someone who has this deformity. So the first one being that it has been found that there is a lack of fusion in the sternal joints. So if you remember the structure of the sternum, we have the manubrium, the body, and the xiphoid process, and just the joints that connect those parts there, they just lack fusion. Now in just a general concept here, we do notice as well that the costal cartilages, so the costal cartilage that attaches the rib to the sternum, so that little section there, they do become less stiff when entering adolescence or teenage years. In addition to that, we do see that costal cartilages are overgrown in children with Pectus carinatum, as well as they have rib undergrowth. And so it's speculated that a combination of all these factors here, and as they grow, a combination of all these factors, abnormal forces occur, which can cause a bowing of the chest wall, which would then be Pectus carinatum. So how is this deformity corrected? So previously it was corrected through surgery. So what they would do is on each side of the torso, they would make 2 incisions. They would then take a curved bar, shove it into your chest, push the bump down, and then screw it into place. So it was invasive and it was very painful. And then somebody came up with the bright idea saying, how about instead of shoving a bar into someone's chest, why doesn't the bar just sit on the outside of the torso and we just push it down? Amazing, right? So that's exactly what happened. So now we have what we call a Pectus carinatum orthosis, or a PCO. So there are many types around the world, but the one that I'm researching specifically was developed by Braceworks. So it's just shown here on the right. And the overall goal of this brace is to just basically push the protrusion down or apply force to the protrusion to correct it. So how does it do that? Well, we have an aluminum bar here that would wrap around the anterior portion of the torso. There is then a pad attached to the aluminum bar, which would sit on the apex of the protrusion. And then we just have some shoulder straps and a back strap, and that just allows it to suspend over on top of the protrusion. So that's just kind of like a guide on where to place it. And then how do we actually apply this force? Well, we have these dials here on each side, these boa closures, and as we turn those, that'll just push the pad into the bump, and then eventually we'll correct it. So there has been literature on this brace before, but it was just a general concept as to whether or not it corrects the protrusion, and it has been seen to correct it. So along with this brace, there is a protocol. It's very original. It's called the Calgary Protocol. So it's basically just an instruction manual for how long the patient should be wearing this brace for. So there's two phases, the correction phase and the maintenance phase. In the correction phase, it lasts for about 4 to 6 months. The brace is worn for about 23 hours a day. And then about every 2 months, we do have a follow-up appointment for adjustments for the brace. Once the clinician believes that the protrusion is fully corrected, we then move into the maintenance phase. So this can last about 18 months or when axial growth is complete. The amount of time the brace is worn is reduced to 8 hours a day. So usually they wear it at nighttime by then. And then we have a follow-up every 6 months for adjustments. So this Calgary protocol here, so this is basically telling the patient how long should I wear the brace for. But the thing is that the brace applies the force to the protrusion. So now the question is who determines how much force they need to wear it at? So if we go to the fitting of this brace, the amount of force is set by the clinician. So as soon as the patient's ready to wear the brace, the clinician comes in, puts the brace on, tightens it to what we're calling the clinician force, and then he asks the patient to maintain this force over the course of treatment. And because this patient needs to maintain the force, that's when we run into issues. And why is that? Because the one flaw of this brace is that there's no visual guides on it. Okay, so as soon as that clinician force is set, that patient is left with their memory alone to recall this force. And what happens is they can return to their follow-up or even before their follow-up appointment over-tightening their brace because there's uncontrolled patient forces. And because they're over-tightening their brace, they can return with skin abrasions or even overcorrection of the protrusion. So therefore, there's a strong need to determine what these patient forces are and how they actually compare to what they're given by the clinician. So in addition to these forces, there is literature and even some surgeons around the world suggesting that the protrusion stiffness itself may influence the brace forces and also the correction rate of the protrusion. So before diving in any further, I just want to define what protrusion stiffness means. So if we go back to our classical definition of stiffness, it's the ability of an object to resist deformation, right? So if I were to apply force to this spring and I were to measure its displacement, the stiffness is simply the force divided by displacement. Simple, right? So if we relate this to the protrusion, so here's a cross section, this very fancy diagram that I made. This cross section of the torso, here's the protrusion there. If I were to apply force to that protrusion and measure its displacement, it's simply the force divided by the displacement of the protrusion. Okay, and then the correction rate. So currently in the clinics, the correction rate is determined by calculating the percent change in the AP depth of the torso. So what you would do is you would just simply measure the AP depth of the current torso and divide it by the AP depth of the torso previously of the individual. In addition, in some of the literature, we have seen that the clinician force and the correction rate is related to age. So with an increase in age, we see that there's an increase in clinician force and that there is a decrease in the correction rate. So why is this? Perhaps it could be because the age is proportional to protrusion stiffness. So with an increase with age or an increase with time, the stiffness of the protrusion might become larger due to the costal cartilages stiffening. Therefore, we also want to investigate whether or not there is a time effect involved with the stiffness of the protrusion and the patient forces. So jumping into my specific aims, the first one, of course, we want to develop and validate a system to measure the forces and the displacement of the protrusion. And after we're able to do that, we want to determine the relationship between the clinician force and the patient force. We also want to find out this protrusion stiffness and if that influences the patient forces. And we also want to find out the protrusion stiffness with the correction rate. In addition to those, again, we want to determine if the effect of time has an impact on patient forces and protrusion stiffness. So with our hypotheses, we do speculate that there will be a difference between the patient forces and the clinician force over the course of 2 months. We do believe that the patient forces will be different over time, and that there will be a positive relationship between patient force and protrusion stiffness. So in other words, as protrusion stiffness increases, so will the patient forces. We expect the opposite to happen with correction rate. So as the protrusion stiffness increases, the correction rate will decrease. And then we do expect to find no difference in protrusion stiffness over the course of treatment. Okay, so getting into the methods here. Regarding back to the first specific aim, we want to develop and validate a system to measure all these forces. So that was easier said than done. We learned that it's a lot harder than we thought, and we had a couple previous systems that were failures. So it took about 2 years to actually develop a system to measure these variables. And so the current system that we have now, it seems to work pretty well. So it basically is composed of 3 main sections. So we have the force sensors here to measure the forces. We have an LED sensor, which would measure the displacement. And then that's complemented with a reflective surface, which I'll get into in a little bit as well. But first, let's get into the specifics of how we measure the force. So if we all remember, we all know what a force plate here is, I'm assuming. So force plates, we basically use that sort of setup to measure our forces as well. So on a force plate, we have 4 load cells on each corner, and those are sandwiched between 2 flat, rigid structures. So the way we measured our forces was something quite similar to that. We had 4 uniaxial compressive load cells placed on the corner of 2 different adapters that were 3D printed. We called them the backing and the replica. Now the backing here, basically we call that the backing because it sits on the back of the pad, so nothing fancy. The replica, the reason it was called the replica is because it just sort of replicated the shape of the pad, the original pad as well. Now on the backing, we had 4 insertion points, and this allowed the load cells, which were epoxied onto the replica, to just slot into the backing, and then they could just remain static while we measured the forces. For displacement, again, we used an LED sensor for displacement. It was aligned with the brace using a tripod. You can't see it in the picture here, but the LED sensor is attached to a wooden board, and then the wooden board back here would be attached to the tripod, and then we could align it with the brace. We then had a reflective surface here, and that just increased the surface area for the LED sensor to reflect off of. Study participants, we had 11 male participants recruited so far, ages 12 to 17 years. So what was their timeline like? So we had 3 time points for data acquisition. The first one being the fitting of the brace, so time point 0, and then afterwards we had 1 month and 2-month follow-up. At each time point, we measured certain variables. So at the fitting, we had the AP depth, the clinician force, the patient force, and the displacement. And then at the 1 month and 2 month, we dropped the clinician force in order to follow the Calgary protocol as close as possible. So the clinician force is only measured at 1 time point. As you can notice as well that we did have all 11 participants at the fitting, but then we only have 10 and 7. This is just due to patient dropout and also time restrictions. So looking at our outcome variables, the way we measured AP depth, so the anterior-posterior depth of that torso, we simply just used calipers, aligned it with the apex of the protrusion, and then we would just measure what the depth was. The clinician and patient force, we had the patient stand against a wall, and then we would measure the forces and the displacements occurring simultaneously while they tightened the brace. And we also used a metronome to control the tightening rate of this brace as well. So while measuring, we took 1 trial of clinician force, followed by 10 trials of patient force. Our reason for only performing 1 trial of clinician force, again, we just want to stay as close as possible to the current fitting protocol at the clinic. For protrusion stiffness, again, we have 10 trials of patient force along with their displacements. So for protrusion stiffness, we would plot a line of best fit against all of the force displacement curves for each trial. Afterwards, the protrusion stiffness would simply be the slope of that line that was fit to all Chen trials. The correction rate I briefly mentioned earlier, again, it's just a % change in AP depth. So again, we would just take the AP depth of the current torso divided by the AP depth of the previous one and just multiply by 100. Statistical analysis, the difference between clinician force and patient force, that was just used using a paired t-test. Protrusion stiffness and patient force over time, we used a pairwise comparison. And then the relationship of protrusion stiffness with patient force and correction rate was with a general linear mixed model. Okay, so jumping into some results here. So let's first take a look at the differences between the clinician force and the patient force. So of the 28 cases we measured, we actually had 21 that showed a significant difference. So basically, 21 cases showed that the patient force was different from the clinician force. So breaking that down in each time point, we had 6 of 11 participants at the fitting that were different. We had then had 9 of 10 at the 1-month follow-up, and then 6 of 7 at the 2-month follow-up. The mean difference that we found was approximately 0.9 kilograms. The smallest difference was 0.2, and the maximum difference, was 2.3 kilograms. Taking a look at the patient force over time, we did see, so if we look on the graph here, we have patient force on the y-axis, and then we have time on the x-axis. We do see that there was a significant difference between the fitting and the 2-month follow-up here. And then there was a significant difference between the 1-month and the 2-month follow-up as well. Now, we don't see a significant difference between the fitting and 1 month. However, we can see overall that there was a trend where the patient force did gradually increase over time regardless. Looking at so because the patient force has increased over time, then it is likely that then the differences between the clinician force and the patient force did increase over time as well, which we can see here. So each of these lines here represent one of the individuals or one of the participants, and then the black dotted line here is just the average of all these differences. So we can see a trend where the difference is increasing over time as well. Okay, so getting to the discussion of these results here, I just want to mention that this is the first time in the world that anyone has actually measured these forces, and we were successful in doing so. Therefore, there isn't any literature actually to base these results off of, and so we're kind of left to look at external resources, such as scoliosis bracing, to kind of determine, why did we get our results. So with that said, being able to measure these forces, again, we did find that the differences between the patient and clinician force was ranging from 0.2 to 2.3 kilograms. The highest force, let me just rewind here a little bit. So with these differences, now we don't know whether or not these differences are actually relevant towards injury. They might be large enough, they might be too small, we don't know. But if we do look at the maximum patient force that was seen, it was around 3.9 kilograms. Now, if you look at scoliosis bracing, now scoliosis braces contain a thoracic pad that would push on the thoracic area. We see that the average forces that thoracic pads apply in scoliosis is around 6 to 7 kilograms, okay? Now, they are larger forces, but scoliosis is dealing with a larger structure, and also the force is being transmitted through a larger pad. Looking at the Pectus, the PCO brace, seeing the largest force being 3.9 kilograms, it is a smaller force, but we are dealing with a smaller structure, and we are dealing with a smaller surface area in which that force is being transmitted. So, of course, we can't say indefinitely, but there could be a possibility that a force of 3.9 kilograms is large enough to cause relevant injury. Okay, so again, with the patient force, we did see that gradual increase over time. Now, this could be simply due to the fact that they just forgot the clinician force. Again, no visual guides on the brace. They're asked to maintain this force through memory. So just over time, they forgot what it was, and they just decided to crank it up higher and higher as time went. There could also be a habituation effect. So at the beginning of this treatment, as you start to push the protrusion down, it is a little sore at the beginning of treatment. However, with the protrusion being exposed to these repetitive forces, it may adapt to these forces, and then the individual may receive an increase in pain tolerance. And so with an increase in pain tolerance over time, they may be able to dial the brace higher and higher without any repercussions. Okay, so let's look at now the protrusion stiffness. So the protrusion stiffness over time, we have the stiffness on the y-axis here and time on the x-axis there. We did not see anything different. So from all the time points, there were no significant differences. In addition, we didn't see any sort of trend within the stiffnesses over time as well. Looking at the stiffnesses for each individual again, so each line represents one of the participants, with the black line representing the average. We don't see any sort of trend in this as well. So again, no change with time. So this was actually expected. This is what we hypothesized. And why could that be? Well, again, the costal cartilages do become less stiff when entering adolescence. In addition to that, during adolescence, it's very rarely seen. The costal cartilages are rarely seen to stiffen until adulthood. Therefore, with our timeline being only 2 months, we may need more time to see any sort of significant differences. When I say more time, I'm talking maybe years, because some of these children or teens, they're starting maybe at 13 years old, and their cartilages might not stiffen until 18 years old. So it might be that the protrusion stiffness doesn't change even throughout the whole treatment. Okay, so now looking at the protrusion stiffness versus the patient force. So no relationship found again, so we didn't see any relationship between them. However, when looking at the patient force plotted against stiffness at each time point here, so each graph represents a different time point, we did see a potential trend where as the protrusion stiffness increased, so did the patient forces. So we saw that at the fitting and the 1 month. However, we did not see that at the 2 months. So as to why this potential trend could have occurred, well, it could be possibly due to the comfort level of the patient. So if we have, so let's just pretend that we have Simon here and Samantha here. Okay, so Simon has a stiffer protrusion, and what was her name? Samantha has a more flexible protrusion, okay? So Simon, who has the stiffer protrusion, so he's gonna be able to dial this to 3 kilograms, and his chest won't displace as much. So he still might have that lung capacity or that capacity in his chest to breathe comfortably. Samantha, though, if she has a flexible protrusion, so if she puts that brace on at 3 kilograms, her chest is going to displace a lot more. And so then we could see that the lung capacity is being restricted, and then she can't breathe as well. So she might need to dial back the brace a little bit and wear it at a lower force. Does that make sense? So we're thinking that that could potentially be due to the comfort levels. However, overall, in the general aspect, we didn't see any relationship. So it could be that the patient forces are actually influenced by other factors. So now, again, let's relate this back to the scoliosis bracing with those thoracic pads. We do, in the scoliosis literature, they do notice that the thoracic pad forces are influenced by the position of that brace. So that could relate to our scenario as well. So the placement of the pectus brace itself, or the PCO, could influence the magnitudes of the forces. So it could influence what angle that the forces are being applied at. So it could be more shear, more compressive. We're not too sure. But that could be a possible solution and would need to be looked into. Okay, so looking at protrusion stiffness versus the correction rate. Again, no relationship found, but we did see a similar trend to that with the patient forces. So now if we see the correction rate on the y-axis and the stiffness in the x-axis here, we do see a potential positive trend where as the stiffness increased, so did the correction rate. Again, at the 2 months though, we didn't see any trend there. So let's talk about this trend, because we expected to, although it's not a significant trend, we did expect to see that an increase in protrusion stiffness would result in a decrease in correction rate. So why is it the opposite? Well, it took us a while to think of a reason, but we do have a potential reason. So it could be that the protrusion is just more, in the quotations, moldable with a stiffer protrusion. So if I were to take, again, well, let's take Simon, and if I were to push his bump down and leave a force there for a long period of time, if I were to release that, the stiffer protrusion may want to stay there. If I have Samantha, who's more flexible, and I were to do the same thing, apply force for a long period of time, because her protrusion is more flexible, it might want to just pop back out to the original position. So it could be that with these forces being applied to the protrusion, the ones that are stiffer, the protrusion just wants to stay there. However, again, the overall trend, though, was that there was no relationship between the two variables. So again, that could be due to other factors. Most important one probably would be the patient compliance. So what I mean by patient compliance, it's just how well they follow the Calgary protocol. So if I have Simon here wearing the brace for 23 hours a day, and then I have Samantha wearing it for 2 hours a day, obviously Simon, who's wearing it for 23 hours a day, is going to correct a lot faster than Samantha. In addition, so let's go back to that scoliosis bracing. So in scoliosis, we see that the characteristics of the spinal curve can influence how fast someone can correct. So regarding back to our pectus carinatum, we see that we might think that the geometry of the protrusion could influence the correction rate. Every protrusion is just a little different. It's not the exact same. They could be symmetrical, asymmetrical. They could be a little different with each person, and that could be influencing how the forces are transmitted through the protrusion and influence the correction rate as well. Okay, so just to quickly summarize for you guys. So again, we were the first in the world who were successful in measuring these PCO forces over time. We believe that there will be a difference between patient forces and clinician forces throughout 2 months, and we did find that. We did see significant differences. We also did see that the patient forces were different over time. We saw that gradual increase over the 2 months. However, we did not see a significant positive relationship between patient force and protrusion stiffness, but we did see that possible trend. As for the fourth hypothesis, we expected a negative relationship between correction rate and protrusion stiffness. We did not see that. However, we did see that there's a potential positive relationship between the two, so the opposite of what we stated earlier. And of course, we did see that there was no difference in protrusion stiffness over time. So just some future work. Of course, recruitment of additional participants for this current study. It's always nice to have more statistical power to your study. For future studies as well, for three-dimensional models of the torso, it would be really good to look at the 3D models. This could give us an idea of what the geometry of the protrusion is and what's happening to the protrusion itself in 3D instead of just one plane. So it can give us a better idea of how the protrusion adapts to these forces and actually the whole thoracic area. In addition, so finally, our current system is limited to just measuring forces in the clinic. So if we could build a system 2.0 with wireless sensors, then we could perform wireless data acquisition. Why would we want to do that? Well, that would be a good way to measure the patient compliance. So we could measure how long are they wearing the brace for. And that could then provide the clinician with real-time feedback, and he can use it as an assessment tool. But it can also provide the patient themselves with feedback, and then that could provide the brace with some visual guidance so that they know exactly what they're wearing the brace at. So they know what the clinician force is, and then over the course of treatment, they know exactly what to wear the brace at as well. So with that, I would just like to acknowledge the following people. My committee, the Ronsky Lab, Douglas Condro for helping me 3D print the adapters, and then of course BraceWorks and MyTax for the funding. Thank you.
Thanks, Thomas. The floor's open for questions.
Is the BraceWorks the company that designed that?
Yes. Yep.
Do they have intentions of working with you do to try and develop something that can give feedback for tightening the brace, or what's their?
Maybe not with me. I'm not too sure. So I mean, so my PhD, like when I start my PhD in September, I do plan on working with different like braces. But I mean, I definitely I do want to work like in the future with them. Maybe if they gather more students to continue this project, I would definitely be willing to help them in the future with that for sure. But yeah, so the long-term goal is to eventually not even, but potentially produce a brace that is just easy to put on. So kind of almost like a template brace where it might not need to be custom made. It can just be basically an assessment tool. So the clinician goes in, he measures their stiffness or something like that. And then he goes, okay, well, your stiffness is X. So you're going to get brace B instead of A or C or D or something like that. So that would be sort of the long-term goal, is just to streamline the process of the assessment and the treatment. So, yeah.
Do you know what's actually happening to the tissues underneath the brace?
No idea. Yeah, no idea. So that was actually, before I started this project, actually, what one of the surgeons thought. So one of the major questions was, we have this costal cartilage overgrowth underneath here. And so people would ask, so what happens to that cartilage after it's corrected? Because they thought that the ribs would be the same length, and so you have this little bundle of costal cartilage, and so people would wonder, well, what happens to that? That was actually what was thought, but then after looking into the literature, we see that the costal cartilages are just longer, but the ribs are shorter, so the overall length is the exact same. So what's actually happening to tissues is they're just being realigned, but regarding like any of the other stuff, the connective tissues, any other connective tissues, we're not too sure.
So what's causing that bulge if it's the same length, I guess?
Yeah, so basically it would just be, so this is my speculation from all the literature I've read, because still nobody knows. But yeah, so we have more costal cartilage, which is a lot more flexible, right? So we have all this costal cartilage, which is longer than normal. And then we have this lack of fusion in the joints in the sternum. And so as you're growing, all these longer cartilages, which are more flexible, might just eventually be exposed to abnormal forces, and then eventually that cartilage might just pop out, and then the sternum will also kind of wing out because the joints aren't fused together, so they can kind of just kind of wing out that way. So that's my speculation. That's not actually, this is no way could be actually happening, but that's just my guess. So yeah.
So with Pectus carinatum and the increased chest volume, do they have bigger lung capacity? Could this be exploited by athletic fibers?
Yeah, so there's actually, so Pectus excavatum would be, is the opposite of carinatum. So when you have a dip in the chest, that's excavatum. So there's a lot of research on lung capacities for excavatum, but not carinatum, because very rarely, like I said, you rarely see any sort of issues with the pulmonary aspect of them. So yeah, usually they're able to function just normally when they have it. They're able to run and play sports and all that. And once in a while, you'll have one patient who becomes short of breath really quickly, but most are able to just go on with their regular daily activities without any issues with lung capacity. And
no added benefit.
Yeah, basically, yeah.
Is there any disadvantage in having different patient force and clinician force?
A disadvantage?
Yeah, is there any disadvantage?
Well, so I mean, if you're over tightening, so
Not over tightening, like you got different forces, right?
yeah.
So is there any problem in having different?
Yeah, so we don't know. So there's no literature to really kind of go back onto this and say, well, this is what they found, because nobody's actually found it yet. So yeah, that is one of the things with our results, is we're finding these differences, and now it's a matter of, okay, so now in the future we should probably track, pain levels for all of the patients and say, okay, well, they had pain and this was their difference, and they didn't have pain and this was their difference, etc. We didn't do that. We just wanted to see what differences we would see at first. But for future work, we would definitely look into that. Yeah, good question, though. Jordan.
Could the issue be solved with the difference between patient and clinician courses by having brace and tightening knobs have like numbers on them?
Exactly. Yeah. So that's exactly what they want to do. But the thing is first we need to know, okay, because the thing is that the clinician themselves, like the clinician himself, he doesn't know what he's putting it on at. He just has his own little system, and he goes, "Can you breathe?" And they go, "Yeah." And he's like, "Well, great. See you later." So the first thing we have to do is just figure out, okay, so what are they being prescribed? And as soon as we know that magnitude, we can go like, okay, so the what they were prescribed, what was their correction rate? Maybe they were a lot slower, so it was like, maybe you could have gotten away with a higher force. And so we could kind of then determine a system being like, okay, protrusion stiffness is this is going to be your force. We're going to give you this brace that can only go up to this force, or only go up to this number, or something like that. But that is literally like the end goal of this project. So yeah, it would be a lot easier that way for sure. That's the thing. Hey, sorry.
You said you did a few trials to measure the stiffness, right?
We took 10 trials.
So did you, in between, you didn't really take the brace off, or did you take the brace off?
We wouldn't take the brace fully off. So what they would do is, as soon as they tighten the brace, we would take our, so we would start the measure data acquisition. They would tighten it. We would let it be for a bit, and then as soon as data acquisition was done, they would just loosen it off, and they would just kind of shift it around, put it back on, and then retighten.
So that's why you see, because there was quite a bit of variation between different trials and stiffness.
So the thing is, so it's not as simple as, the tough part with measuring the stiffness of the protrusion is usually when you see literature with stiffness, it's homogeneous materials. So it's, well, not homogeneous, but it's like cartilage, skin, all that. So we're actually dealing with all of that. We have bone, skin, cartilage, and it's all coming in as one. And so the stiffness is going to vary a little bit here and there. And so basically it's just almost called like a bulk equivalent stiffness, I believe. But yeah, so basically it's just a matter of, okay, how's that force actually applying to the protrusion? And that's going to maybe influence the displacements. And so we do see a little bit of variability in that.
Did they try to like hold their breath, or?
No, yeah, so we didn't control for that. That's actually a really good point. So we didn't control for that. So we would just basically let them tighten and then just sit still for a bit. We didn't tell them to control their breaths or anything like that. But that couldn't actually influence the stiffness values for sure, which could be due to the variability actually. Yeah, that's a good point.
Did you find some gender differences?
We only had males.
Okay.
So I guess it was bad to say Samantha, and I should have said another male name. But so basically, the reason we didn't choose females though is because females can develop Pectus carinatum. So scoliosis is about 4-to-1 female to male. Pectus carinatum, swap those, and then it's 4-to-1 for males. And the thing is with the female braces though, either it has to be sort of adjusted to accommodate for like the breasts development. So if it is early enough, they can use the brace that was shown earlier with just the pad there. However, it does wrap around the pectorals. And so with a female, if they start early enough and they can get rid of it early enough, then it can work. But if they start to develop breasts, then what they have this little modified version where it sits lower down, and then there's like a little extension to sit between.
Do you think you should apply it to girls at an earlier age because of differences in
Well, so it depends when it develops, right? So it can develop anywhere in adolescence, so anywhere in teenage years. So you can have people coming in at 10. I think I had one, so I think the youngest I saw was maybe 11 years old, and then the oldest I saw was 17. 12 to 17. Youngest I saw was 12, and then one at 17. So it all depends on their age. So a female could come in at 17 years old, and by then, obviously, she's gone through puberty, and so sometimes you need to do the modified, or they might go into surgery instead. So surgery is still a fallback in this case.
And does this abnormality progress over time?
That's a good question. I don't think so. Like, judging from some of the people that I have met who are, because Braceworks does sometimes try this out on people who are in their 20s who just never bothered with the treatment before, and then they say, "Oh, I never knew about this bracing and stuff." And so when they come in the 20s, it does seem like it's about the same amount of severity, I guess you could say. So whether or not, I couldn't say for sure, but I think it might just stay relatively the same. I don't think the severity would increase, but it could.
Yes.
So how is this diagnosed and then measure also this? Do they become medical professionals?
No. So this is gonna sound so bad. I'm sorry for the surgeon who's on my committee. But so basically, when he sees the patient, and it literally is just, yep, that's pectus carinatum. You might need a brace, and so that's basically how it goes. So there's no severity levels or anything like that. Usually, you just base it off of, you look at it and you go, yeah, that thing's sticking out pretty far, or it's a mild one, but there's no actual measurements to determine what the severity of that. And then what was the first question there? I forgot that one. You had one before? Oh yeah, totally just visual. Yeah. So basically, and as this is coming from the surgeon himself, I'm not going to put a name out because it might embarrass him. But basically, yeah, the patient comes in and he goes, "That's a bump on your chest. That's pectus carinatum." So yeah, that's usually how it goes. And yeah, it's all just visual. Yeah. Okay.
In that Calgary protocol, theoretically, they only have a constant force throughout the whole period that they wear the brace, correct?
Yes.
So why do they not change it over time? Is there a reason?
The amount of force?
Yeah.
Because they don't even know what the force is, right? When the clinician sets the force for the correction phase, so that time where they wear it 23 hours a day, basically and this is why we only did clinician force at the fitting, because literally it is just right at that time point 0. He puts it on, he says, wear it at this for the rest of the time. And he doesn't even bother checking the rest. Unless they complain, he doesn't bother rechecking what they're wearing it at. If they say, oh, it's fine, then he doesn't bother checking the amount of force. But then again, what is the amount of force? So we don't know how to change it. But that could be exact. So this is exactly why we're doing this research, because over the course of treatment, the forces may need to change, right? Because as they're correcting more, maybe we don't need to press down as much anymore, because then that could lead to overcorrection. Who knows, right? Yeah, good question. Yeah.
Are there any changes in the back of the sites associated?
Yeah. So as the protrusion, as that AP depth goes down, we actually see that there is a relationship. So say the bump went down a centimeter, we would usually see that then the medial lateral width also went out a centimeter. So as we push this down, this comes out a little bit as well. So that's usually the trend that we see for that. So that's why we'd also want to look into the 3D models of the torso, because then we can see, we can then see what's happening all around the torso as well, see if there's anything else going on. Yeah.
How many times is the correction device is loaded? So I mean the cycle. About the key on the device.
So how many times do they have to tighten it up every time? So that's all user dependent. So if they're very active and they're constantly playing sports, they're not supposed to wear it playing sports, because you're already applying, like I said, one person's putting it on at 4 kilograms, so about 10 pounds. So imagine getting hit after you already have 10 pounds on your chest. So that would hurt, right? So yeah, if they're involved in a lot of activities, then they might need to take it off, need to put it back on. And it's funny you mentioned that, because there is little plastic pieces. Let me see if I can get let me get the picture of this brace. Okay, so the brace here. So we do have, so this is where the bar ends, and then we have the strap continuing. And there actually is a little plastic piece in there. And what we see is that this is actually failing quite quickly at the moment, just because every time they're putting it on, we're just applying more forces, and then this has the tendency to snap, and then they need to replace it. But
another question
yeah.
about the protrusion stiffness.
Yeah.
So you're measuring the stiffness, but I'm thinking because this device for measuring the heat,
Mm-hmm.
the metal. So the displacement should be different, because the stiffness of the device also has changed.
Mm-hmm.
So the stiffness that you are measuring using this device and the old cell should be different each time.
So you think so the metal should be fatiguing, the aluminum bar, like this section of the brace here. So that would be fatiguing. So that would influence the displacement of the protrusion.
Because it's more than the yield point of that metal.
Mm-hmm. Yep. Yep.
So it's very likely that the stiffness can be over time instead
Of the bar. Okay.
that's one.
Yeah. I'll have to talk to my supervisor about that. She's the mechanical engineer, so. Yeah, that's a good point, though. Okay, thank you. Yeah. Oh, actually, yeah. Good.
Ricky?
I don't know if this question makes sense, but when you measure the stiffness, you just measure like the initial and the end point of displacement.
No, so we would have like a full. Yeah, so we would have a full force displacement curve. So if I go back to this slide here, so if we have this slide here, so basically this is the force and displacement in real time as they tighten the brace. And then we would just fit a line against all 10 trials to obtain the stiffness.
I was just thinking that it might be that
Yeah.
the initial stiffness could change.
Mhm. Yeah, absolutely. Well, I mean, there are a lot of limitations with the way we measured the stiffness because obviously we don't even know what the linear portion of this would be either to calculate the stiffness properly. Because again, we're dealing with skin, cartilage, and everything. So we don't really know where that linear section starts. So it's a little shot in the dark, but yeah, it's the best we could do at the moment. But yeah, there's definitely a lot of limitations with the way we measure the stiffness. Yeah.
How long this process takes, like capacity of the brace?
Like to tighten it. So it can vary, but on average, like all they have to do is dial it maybe 4 to 5 times, and then they're like, yeah, I'm good. So that's tighten it. Yeah, a few seconds. Yeah. So average data collection was about 30 seconds.
You ask subject to hold the brace because like
Mhm.
movement of the chest makes us.
Yeah, I guess I could have them hold their breath while they tighten there. Yeah, I could.
We didn't have any control on the movement of the.
Yeah, that's another limitation is because we have the breathing. The thing is the LED sensor, right? It'll be going up and down like that. But we do try to filter that out. But yeah, no, that's.
There are no further questions. Thanks very much, Thomas.
Okay, thank you.
Next week's presentation will be by Nita Fung. She's a MSc student with Dr. Brent Edwards. The title of her seminar is Experimental Validation of Finite Element Predicted Bone Strain in Human Metatarsal. Thanks for coming. Have a great evening.